Margaret, lovely introduction. My name is Andrew Sun. I'm a urologist here at UPNT, and I basically direct the men's health center. So my whole practice is just doing guy stuff, right? We're at the main Arlington hub. That's kind of where me and some of the PAs that I work with kind of reside. And in our sort of world, we basically try to help men lead better quality of life. And that comes down to two things that I focus on, which is sexual function, erectile dysfunction, and sometimes incontinence, where we have actually a whole bunch of doctors here that does that as a team. So we're going to start the talk. For most of it, will be about erectile dysfunction, and then sort of, let's say 75%, and then the 25% at the end will be about stress incontinence. Because these are both kind of very common things, although certainly erectile dysfunction is probably the more common of the two. So ED, you can define it any way you want, but basically it's when it doesn't work good enough that you want it the way that you want it to, right? So it's either the inability to attain or maintain an erection satisfying enough for having sexual intercourse. And the second part is actually important because a lot of people can attain an erection, but many of people have trouble maintaining an erection. And most people just think about the blood flow going in, but you got to keep it in there too. It's also super common. A lot of people think this is like a rare disease, but it's probably I tell people it's the same percentage as your age. So 50% at 50, 80% at age 80, 100% at age 100. It's a super common condition and it's nothing to be embarrassed about because it's usually something that is a result of other medical problems. And it's usually something that we can fix with a variety of options, which is what we'll talk about tonight. Very briefly, what happens when you get an erection? The penis is a muscle, like it has smooth muscle, but it's still a muscle. And like any other muscle in the body, if you don't use it, you lose it, right? So there is some shrinkage that can occur with erectile dysfunction. So if for no other reason than to prevent shrinkage, when you start having erectile dysfunction, you should kind of get it looked at. So what happens normally, basically the smooth muscle relaxes, the blood comes in. When enough blood comes in, it compresses the veins on the outside of the penis so that the blood can't leave. Now that can be damaged or basically injured in some men just through aging, through certain, procedures and whatnot, such that you have what we call venous leak. And this is where you get the blood to come in, but the exit blood vessels just don't crimp off well enough to keep the blood in there. So you basically can get it up, but you can't keep it up. That's probably the first thing that happens. And then it's hard to get it up, but you still wake up with morning erections because morning erections actually have a separate mechanism in which it's a little bit related to bladder filling. It's a little bit related to your spinal cord, but it's a different style of erection. And then eventually you don't even get morning erections anymore. Then that's when you know you have like really bad ED, right? So first you can't keep it up, then you can't get it up, then you don't wake up with morning wood anymore. That's kind of the three stages that most people go through with erectile dysfunction. So lots of things cause ED, and in general, in the men's health world, we think of the penis as whatever analogy you want to use. We call it the canary in the coal mine, right? It's the first thing that men tend to notice there's a problem with because let's be honest, we're guys, and that's what we kind of pay attention to more. And when you start to notice problems in the penis, it's usually a sign that there are other problems happening somewhere else in your body. Now, those other problems can be aging, because that, unfortunately, an 80-year-old penis just doesn't work the same way it does when you were 18. But other things that just generally seem unhealthy for blood flow, smoking, diabetes, high blood pressure, high cholesterol, those are all probably the most common causes of erectile dysfunction from a medical side. And you can see a sort of vascular diabetes. Notice what I did not say directly, which is low testosterone. Low testosterone can be associated with erectile dysfunction. But one thing I want you to remember is that testosterone is a brain hormone. It controls how horny you are, your libido, your sex drive. It's not directly control the flow of blood into your penis. Certainly when you have low T, things won't work as well, but fixing testosterone is not going to magically fix the blood flow issues inside the penis, right? But it is a piece of the puzzle. And certainly, we don't want to make light of ED as a diagnosis. I mean, a lot of people chat about it and they're like, oh, you treat ED for a living. I'm like, yes, and I'm also treating people's relationships, people's marriages, their self-esteem, their confidence, and a lot of psychological things that kind of come along with those feelings of just not being as much of a man anymore that can happen when you have significant erectile dysfunction and when it's kind of been an issue for a long time. And so, we definitely know that this causes a lot of depression, anxiety, and different things like this. Sometimes when the guys are single, this actually prevents them from wanting to go out and date again because they're not confident that, if they find a new partner, and what if the time comes and they're not able to perform, then everybody's disappointed and unhappy. And so I might as well just not even go date. So the ability to restore that confidence in a guy and give them that gusto, that energy, that confidence to go out and sort of get out there again, it's also a nice part of what I do, and it's part of why I really enjoy my work. So other things. So if you had to pick one disease to not get when it comes to your penis, it's diabetes. And unfortunately, because of our terrible food here, we got a lot of it. And diabetes hits. So there's four things you need to get an erection: blood vessels, hormones, nerves, and psychology. Usually, if everything's working, the psychology will work, but we have some young men with ED, and sometimes a little bit more, if they don't have diabetes and high blood pressure, then you start to think more about the psychological side. That's not to make light of it, because it's a legitimate thing, but that's part of it too. Unfortunately, diabetes affects both the hormones, or actually all the hormones, the blood vessels, and the nerves. So it's affecting everything, which is why it's the worst thing. And diabetic patients just generally do not respond to the ED meds like Viagra and Cialis as well, because those meds actually increase blood flow to the penis by working through the nerves. And because diabetes affects the nerves, the pills don't work as well. And so if you're a diabetic and you've noticed that the Viagra and Cialis that might have used to work doesn't work as well anymore, it's probably because of the diabetes. And basically it damages the nerves and the blood vessels and everything. And it's just not a good time. The other thing that unfortunately diabetes causes also is what we call corporal fibrosis, or hardening of the elastic bodies of the penis. So here's a good point. The penis is a very, very elastic organ. It's a very unique organ. It's the only organ in the body that dynamically changes size and shape to such an extent, because it's a balloon. But the balloon can become less stretchy. It can become less elastic. It can become crispier, whatever you want to call it, but it's not stretching out as much. And so men will see this as penile shrinkage. And there's one thing that most guys never want to hear, it's penile shrinkage. But unfortunately, non-use of the penis, i.e. having erectile dysfunction, diabetes, those things cause penile shrinkage. Heart disease, also big common thing. Most of the guys who have diabetes, they probably have some heart conditions. If a guy comes in, he's like, oh yeah, I got a medical history of cardiac bypass and 3 stents and blah, blah. I don't even have to ask him if he has ED. I know he has ED, because if the disease was bad enough to affect your heart to that extent, it's definitely affecting the blood vessels in the penis. Because on the left here, the penile artery is actually pretty small. The heart artery is a lot bigger, and then even bigger than that are the ones in your neck or like in your femoral artery. So if you have peripheral vascular disease, if you have carotid artery stenosis, if you have any of these atherosclerotic diseases, there's no reason to think that these, plaque gumming up the blood vessels is only doing it in your heart. It's also doing it in your penis. And unfortunately, the penile blood vessel is so small that we can't exactly put a stent in it. And that's a question I get asked a lot. Hey, I've got a stent in my heart. Can't you stent my penis? Maybe someday we'll have something like that, but for now, the blood vessel is too small to get a catheter in there to get a stent in. So once it's cooked, it's kind of cooked. Yeah. So how can you reduce the risk of ED? Basically, be as healthy as you can be, exercise, get good blood flow, do not smoke. Maybe don't drink too much. I mean, every kind of guy knows, right? I think a little drink maybe helps, but then if you drink too much, then stuff doesn't work anymore. And that's physiology. But basically, if it sounds like it's healthy, it's probably good for your penis and your fertility. And if it sounds like it's not healthy, it's probably not good for your penis or your fertility. And the last one here, stress, is actually really important, because if you think about the way that like evolution works, there's no evolutionary understanding of, stress when it comes to sex. The body only knows 2 systems: fight or flight, and rest and digest, we call it. Sympathetic, parasympathetic. Run away from the lions because they're coming to eat you, or chill out and, digest your food after a meal. This is where you want to be when you're having sex. But if you start to have psychological anxiety, which is a very normal part of the sexual experience with a partner, especially if you already have ED, then you start to turn this system on. And this system was created to basically secrete adrenaline, epinephrine, to close the blood vessels to the non-essential things like your penis and move them to your brain and your legs and your muscles, so you can run away or fight the lions or whatever it is. So the psychology of anxiety around having sex creates a physiological response that actually tightens the blood vessels in the penis and basically causes you to lose an erection. So that's why we always say, like, don't think about your penis too much. And every guy, you start to get ED and then you start thinking about it too much and then it's worse the next time. And yes, that's psychological, but that's also creating a biological response, which is the issue. Now we talked about low T before, and I said low T is not the cause of ED in most men, but it is a piece that affects it. And although everybody thinks that low T just goes down as you get older, I have old patients, with really high testosterone, and I have young patients with really low testosterone, because the thing that actually affects testosterone the most is basically also being healthy. Obesity, sleep apnea, not moving around a lot. This causes low T. Low T causes low energy, low muscle mass, low sex drive, and can therefore secondarily impact your erections from that state. So, get your testosterone checked. Every ED patient that I usually have come in, part of the workup, we check their testosterone. We might check their blood sugar if they don't have a primary care doctor to look if they have diabetes, different things like that, because we're trying to look for the cause. And if they can fix some of those causes, it can prevent their ED from getting worse, although it may not necessarily turn back the clock and make it better, depending on how long they've had these issues, right? Men are not as good as women by a long shot at following up with their healthcare and seeing their doctor. Let's just call it for what it is. And so, a lot of guys can start to get some of these issues in their 30s and 40s when, like, and I'm guilty of this too. Like, I don't probably go to the doctor as much as I should. I mean, I am a doctor, but, it's a guy thing. It is what it is. But look at your penis. If it's not working, that's a good time to go to the doctor. Low T causes lots of stuff. I won't belabor the point here, but the biggest ones are fatigue and low sex drive, right? So we can treat testosterone in a lot of ways, and treating the testosterone definitely can help the erections, roughly 20%, right? This is not the magic bullet. This is not, oh, let me shoot myself up with testosterone and my penis will be like I'm 18 again. You might be horny like an 18-year-old, but your junk is not going to work like you were 18 necessarily if the blood flow is still compromised in there. So, what kind of options do we have? There's basically every version of testosterone replacement therapy that you can think of: cream, injection, pills, pellets that we put under your skin that last for a few months, lots of different things. We do basically all of it. I can't tell you how many thousands of patients that I prescribe testosterone for. It's a super common thing. Of course, if you want to naturally increase your testosterone, sleep well, move your body, and eat right, and then if you need a little help, well, that's where our medications come in. And so let's just say most commonly people are either doing testosterone injections once a week, or they're taking pills usually every day, or they may put a pellet under their butt every 3 to 4 months or something like that. And that can help one of the 3 or actually 4 elements, which is the hormonal part. But because it's not helping the nerve or the artery or vascular or psychological part, well, actually it will help the psychological part a little bit too, because the hormones make you feel, so 2 of them are not being hit. So that's why it's not like the be all end all there. Peyronie's disease. This is a condition. It's not a disease. I hate the fact that it's called a disease, but we call it for what it is. It's Peyronie's. That is basically scar tissue in the penis. And this is much more common than you think. It's about 10% of men. It tends to predominantly occur in men of Northern European descent. We believe that the genetics started with the Vikings and basically spread with the Viking conquest. So you're talking Scandinavian, British Isles, German, Northern France, whatever, Eastern European, a lot of things. Not exclusively. You don't have to be one of those to have Peyronie's, but it tends to be the strongest there. And what this is basically that balloon of the penis that's normally a nice sort of easy symmetrical blow up. You put a piece of tape on the top of it. And so if you take that balloon, like think about the long balloons that you'd go to the carnival and fold into a dog, but you slap a big piece of tape on one side of it. Could be the top, could be the bottom, could be the side. When you blow this thing up, that side is not going to expand as much as the other side, and it could be a curvature, it could be an hourglass, like an indentation, it could be going down or up, and it's associated with erectile dysfunction as well. So that's another thing that sometimes comes together that we have to simultaneously treat. For Peyronie's, there's not really any medications directly for the Peyronie's per se. You can give medications that increase erections because we think that men become susceptible to Peyronie's disease through trauma that occurs when your penis is not that hard, but you're still using it. So when you're 18 and you got a 100% solid erection that you can hang a towel off of, you're not going to get Peyronie's really. But when you're 40, 50, 60, and you're like, 85% erect, still serviceable, you can still get the job done, and you have the genetic predisposition, and you eat, it doesn't have to be necessarily a big traumatic event, even just sex, wear and tear on the penis can cause that can cause Peyronie's disease. We can cut things out. That's difficult. And then we also have penile implants, which is primarily a treatment for erectile dysfunction, but is also the perfect treatment for a guy who has simultaneously significant erectile dysfunction and Peyronie's disease, because you can basically solve everything in one go. There's also, there's not on here, there's actually one FDA-approved medication specifically for Peyronie's, which is an injection called Xiaflex, which basically melts the scar down. And that's also a treatment option for Peyronie's. Now, many of the men on this call perhaps do not have a prostate because maybe it was removed because it had prostate cancer, or it was radiated because you had prostate cancer. Every man, no man has ever undergone prostate cancer treatment and came out at the end of it with better erections than they went into it with, right? Doing something to the prostate, whether it's surgery, whether it's radiation, is going to hurt the erections. And so it's always a little bit worse afterwards. It just depends on how much worse and how bad it was to begin with, and a lot of things like that. Because the nerves to the penis are on the backside of the prostate. So whether you peel them off but still kind of stun them, or if you have really aggressive cancer, you had to cut them, or if you radiate the whole thing, that is going to affect the erectile function for sure. Fortunately, prostate cancer has been treated, and generally the treatment of prostate cancer is very good at making sure the guy doesn't have cancer and that he's alive. And then it's basically my job to try to fix, the erections and the urinary leakage that can occur, which we'll talk about later. So I just said that, right? So yeah. After prostate cancer surgery, the nerves do heal, but they can take up to 2 years to fully heal. Probably 70% the first year, 30% the second year. You can occasionally get even a little bit more healing after that. After which you're kind of just getting older, so that it's not really healing any faster than you're getting older, right? So it does take time, it does take patience. We have some things that can help, by stretching the penis and that kind of stuff, but it is definitely a common cause of erectile dysfunction, because prostate cancer is the most common solid tumor in men. Well, yes, we got options. That's the biggest thing, that I started sort of prostate cancer survivorship clinic because I have basically given up 90% of what I learned in urology. I don't do anything with the kidneys. I don't do a lot of kidney stones or ever. They're on call. No bladders, no most of that stuff. I just focus on one organ, well, two, which are the penis and the testicles. And so we created a sort of prostate cancer survivorship, thing where a lot of guys will, if they're not sort of getting back to where they want to be, they'll come and see me, after treatment for prostate cancer, and we'll basically work on the quality of life issues. We got a lot of great surgeons in the practice that are really good at curing cancer, and then it's my job to basically improve quality of life after all that has happened. All right, so now we get into, well, okay, all that's good stuff about, what causes ED, what can you do about it, right? And there's a lot of things. And I like alliteration. And so basically we'll go through all these, but there's pills, there's pokes, there's pulses, there's pulling, there's procedures. That's basically what you can do, right? So on the pills, everybody has heard of Viagra and Cialis. They work pretty well when you're young and healthy, and they work less well over time because fundamentally the penis is aging, and they tend to work less well even more in, like we said earlier, diabetics, and sometimes in prostate cancer patients too, because they work by going through the nerves. There's 4 of them: Viagra, Cialis, Levitra, Stendra. You can mix and match them. You can compound 2 of them together, like Viagra and Cialis, because Cialis lasts longer than Viagra. You can do all sorts of stuff with them, but they all work at the same one enzyme, which is why they're called PDE5 inhibitors. Phosphodiesterase 5 is an enzyme that breaks down nitric oxide, which is what's in the penis that helps you get an erection. And so, that's how that works. It might work, it might not. They can cause some side effects: headache, runny nose, dizziness, back pain, acid reflux, all sorts of stuff, right? But that's where we usually start. Hey, you got some ED, never tried anything, try some Viagra, try some Cialis, we'll see how that goes from there. A vacuum erection device was invented by like a Ford motor engineer in like 1910 or something like that. And it's a really simple but really elegant concept, which is a plastic tube and a pump on it. And you basically put the pump on the penis and you pump it, and it creates a vacuum which draws blood into the penis. Now, this is a great, great way to exercise a penis. And I love a vacuum erection device in a guy that has significant erectile dysfunction because, like I said at the very beginning of the presentation, use it or lose it, right? Length loss happens due to erectile dysfunction. If you put your bicep in a cast and don't move it for a year, it's going to get smaller. If your penis doesn't move in a year, it's going to get smaller because it's a muscle. And so you have to exercise that muscle. And if it's not doing its own thing, like, you know, basically a morning erection, right? Sort of running a system diagnostic and making sure everything's okay by itself, then you got to do it for it. And you do that with a vacuum erection device. You can get these on Amazon for like 30, 40, $50. You can get them from our pharmacy for like a lot more than that, because we use a sort of medical grade device that is a little bit more robust and has some other, kit and caboodle stuff and has a warranty and all these things. But those I recommend for men that are going to use this long term, because a lot of the complaints with the ones you get on Amazon is that they break quickly. But if you just want to dip your toes in and try it, you don't have to go to some like, shady store in, a funky part of town. You just have to go online and go on Amazon and type in penis pump, and you can buy a pump. They're plastic tubes with a pump on it, right? But as anybody who's ever tried to use a pump to have sex will tell you, it's not exactly the best direction, not exactly the most fun, it's not exactly the most comfortable, so don't love it either. Intravenous injections. Basically, this has been around since the 1970s. I'll take 2 seconds and tell a story. The urologist that invented this actually went on stage at a national meeting, dropped his pants. This is back when you could do that kind of thing and not go to jail. And because all the urologists were men, injected himself, and he's told the audience, look at that, I haven't had an erection in 5 years, and now look what I got. That's actually a true story. But you can do this, and you can do this at home. Now, you have to stick a needle in your penis every time you want to have sex about 3 to 5 minutes before having sex. Not the funnest thing in the world. Not actually as painful as you might think, but certainly not fun. And so probably the biggest things that people don't like about this are the timing and the spontaneity or the lack thereof, because you got to like get in the mood and then, oh, hold on, let me go to the fridge and get the thing and drop the needle and do the shot. And it's not a good situation. Also, you're sticking a needle in the penis, so bleeding, scar tissue formation, stuff like that. But it's like 5 times more effective than the pills. So if the pills don't work, this is a reasonable option for you. And we do it actually fairly frequently because, a lot of people want to try something a little bit more aggressive. The most effective solution ultimately is a penile implant. And a penile implant is essentially a knee replacement of your penis. If you got knee pain, what do? You take Advil. Advil stops working, you do like a steroid shot. Steroid shot doesn't work, you get a knee replacement. We got Viagra, we got injections, and we got penile implants. Kind of the same thing. We also have physical therapy. With a knee, the physical therapy is your muscles moving it. With the penis, it's the vacuum pump. And then, there are I'll just take a side, there's some other interesting things like shockwave therapy. That's a fairly new thing. It was developed in Europe, and it has some decent efficacy, mostly in men with on the slightly more milder side of erectile dysfunction. That's a procedure that you come in and we basically take a little gun and shock your penis. Doesn't hurt. We think it helps rebuild blood vessels. Not going to work on a guy with severe ED, but maybe can help a younger guy with more mild ED, right? What the penile implant can help anybody, even the guy with the most advanced erectile dysfunction in the world, because you're not relying on your natural body systems anymore. You are relying on an artificial device to maintain and to attain and maintain the erection. You basically pump it up, and it's totally inside your body. It's all concealed. There are several different types, but I would focus on basically the ones on the left, which are the orange ones, which are essentially balloons. They're balloons that you put inside the penis. There's a reservoir, that little thing floating in the back, that gets put behind your abs. You will never see that or feel that. Even if you have a six-pack, you won't see that or feel that, but I doubt there's that many guys that have that. I don't. And what you interact with is this thing that's the pump. The pump sits in your scrotum. It's like you have a third testicle. If anybody was to look at you, they could never tell that you had an implant. They'd have to feel your testicles pretty carefully and kind of know what they're looking for to think that something was wrong. But it looks natural, it feels natural, and everything else about the sexual experience is the same. Desire, libido, ejaculation, orgasm, nothing changes. All this does is it gets you an erection that you can rely on and you can maintain, because you have to hit a button on the implant to deflate it, which means even after you orgasm, you will still stay hard. You just have to hit a button to make it go down, which means you can marathon it if you want. I mean, hey, to each his own, right? So how does this work? The reason why those things are orange is because it's actually impregnated with antibiotics, which I really like because it helps decrease the risk of infection, which is something that all surgeons kind of worry about. Really natural. They've been around for 50 years. This is not actually some newfangled technology. And 500,000 patients, and counting have been these implanted. This is a surgery that I do about 200 a year of. I think I pretty much do the most of this surgery of anyone in Texas, and it's kind of like my thing because I'm the erectile dysfunction specialist for our fairly large group of 33 urologists. And so, my favorite surgery in the world, I guess. You get to take guys and you get to give them back functionality that they've lost, which not only helps them physically, but also emotionally and psychologically. It's a lot of fun doing it as well. In the end, well, no, this is important. So let's see if I can just kind of play this real quick and I'll try to narrate it. Basically, everything's inside, right? Nothing's sticking out of you. It's all inside. We only make a 1-inch incision and the surgery takes 45 minutes and you go home the same day. It's not exactly major surgery. When you're done, you basically reach down in your scrotum, you feel around, don't squeeze your balls, you squeeze the pump. The pump moves the fluid from the reservoir into the penis, causing the erection. The erection is there until the end of time if you want it. And then you hit a button that basically makes it go down and it goes back into the reservoir. You don't have to refill the tank. It's not, you don't have to like somehow take it out and like fill it up. It's a closed system. It just goes back and forth and back and forth. And they usually last 15 years plus, something like that. So that's how those work. Yes, so it's outpatient, meaning you go home the same day. You usually, you are under anesthesia for this. I tell you my specific things. I do surgery on Tuesday. I do 5 every Tuesday. You probably want to chill out at home for a few days. It'll be a little bit sore, but the average number of pain pills people take is like 3 to 4. You come back Friday, we take out a drain, we deflate the implant. You're pretty much back to your normal life by the weekend, but no heavy lifting or aggressive exercise for like 2 to 3 weeks. And then it'll be about 4 to 6 weeks before you can have sex. And then you should be able to have sex as much as you want, as often as you want for 15 to 20 years or so, the lifetime of the implant, basically. The other thing that's really interesting about this, if anybody out there has Medicare, Medicare fully covers this surgery. I know it's surprising because Medicare doesn't cover a lot of things, but I always tell people to think about who the demographic of the people, i.e. the men, who wrote the laws for Medicare and what they wanted out of life, right? So Medicare covers penile implants, really cool. A lot of commercial insurances cover it too. Some don't. It's just something that we'll have to look at if you do decide to come in and just talk about stuff. We'll check your insurance company and all that kind of thing and see what covers it. It's part of the thing. But the one thing, any government insurance, Medicare, TRICARE, VA, Blue Cross, federal employee, stuff like that, definitely covered, right? That's the one I can name off the top of my head. So the idea here is basically to get, an erection back. Satisfaction is super high. It's like 95, 97%. It's actually like 3% higher when you ask the women, because the women are like, and this is for heterosexual couples, are like, hey, I've never been with a guy that can outlast me, right? I mean, that's a unique situation for most of us. Most of us don't last as long as our female partners. It is what it is. But and it's very natural. It's all inside your body. You don't have to worry about like looking weird at the gym or something like that. If you want to, you can leave it halfway pumped up. But again, to each his own. Got a lot of interesting patients, do a lot of interesting things. Every surgery has risks. The risks of surgery are just having surgery. Obviously, there's some risk to you, especially if you're really sick, right? Cardiac problems, stuff like that. But the surgical risk, specifically bleeding, pain, infection. Bleeding, we leave a drain, not bad. Pain, a few pills of heavy pain medication, and otherwise some Tylenol and Motrin. Infection, the national penile implant infection rate is about 3%. Because I do so many of these, our infection rate luckily is about 0.5%, especially when you use the Boston Scientific device, which has an anti-infection coating. And so, look, that means 1 in every 200 guys, basically 1 a year will still get infected, and it's terrible, and it sucks for the guy, and it sucks for me, and we try to do everything we can to avoid that, but luckily it's extremely rare, and even in those cases we can wash them out and come back another day and do it again. So that's kind of the ED piece of this, which is most of it, and I'll kind of breeze through the next section so we can answer some questions. But basically, super common. Lots of different causes, lots of different treatments. There's a right treatment for everyone. You don't have to think that there's nothing you can do, because I kind of tell people, like, there's not much you can guarantee in medicine, but I can pretty much guarantee every guy walking in my door that I can get him an erection. Just depends on how much work it's going to take us and how much the guy's willing to go through, right? But we can get it working. So that's ED. And again, it's totally normal. It's a big thing, let's talk about it, right? Now, stress incontinence is definitely more rare, but extremely common for men who have had prostate cancer. Occasionally, it can happen through other things, a really aggressive, like prostate opening surgery called a TURP. But nowadays, it's mostly for men with prostate cancer. The prostate sits in front of the bladder, And the prostate does two things. It makes semen and it causes you problems. We sort of joke that if God made the prostate a semicircle instead of a full circle, we wouldn't really have a job, because the fact that it's a full circle is where the problems come in, because it blocks the urine. But that also means that it keeps the urine from leaking. And so when you no longer have a prostate, you can leak some urine because you just don't have that thing there anymore. And actually, the word prostate is Greek for guardian, I think. So that is the most common. And certainly if you have, unfortunately, a bad case of prostate cancer and you had to get both surgery and radiation, it's going to be worse. Just the more things you do down there, the less good things get. But for sure, the prostate cancer thing is the most common. Now, almost everyone will have leakage immediately after prostate surgery. Pretty much universal. There are occasional people that get lucky and never leak a drop, but most people expect you have the surgery, you start leaking. For most people, that leakage will resolve. It may take 3, 6, 9, even 12 months to resolve, but for 85, 90% of people will resolve. However, there's another 10 to 15%, 9 to 16%, whatever, of people who still have persistent leakage after that year that's still bothersome enough to really affect their life. Because if you just have like, oh, occasionally I sneeze and I have a drop, that's yeah, ideally you wouldn't, but that's not really bad enough to probably go through a surgery. But if you're still in 2, 3, 4 pads, diapers, whatnot, we have easy surgeries that we can fix that, and you don't have to leak anymore, and it's definitely going to be helpful. And this is obvious. Why does prostate surgery cause leakage? Because you remove the prostate. So things that you can do. You can cope. You can wear pads. You can wear diapers. You can use a clothespin on your penis all the time. Physical therapy, very helpful. We recommend everybody post-prostatectomy to do pelvic floor physical therapy, Kegel exercises, and that kind of stuff to strengthen the muscles. A lot of people will basically dehydrate themselves, which is not good for their system, because they're just trying to avoid having to leak more. And that's a coping mechanism, but not exactly a good thing. Or you can fix it. And there's two ways that you can fix it. There's a sling, which is an augmentation to your existing sphincter, and there's an artificial sphincter, which is a replacement for your sphincter. So if you have quote unquote mild to moderate stress incontinence, and that would be 1, 2, 3, maybe 4, at most 5 pads a day, no leakage at night, but kind of when you cough, when you sneeze, when you lift something, when you squat, like that kind of stuff. This is a 1-hour surgery through a 2-inch incision in behind your scrotum, kind of between your scrotum and your anus. Go home the same day and you can basically be dry. It's pretty amazing. And essentially, yeah, the idea is you put a little hammock in there, you just sling it up and you tighten it. Peeing with this thing is totally like normal. You don't have to do anything special. You just pee. It's just that you leak less. Very nice, very elegant procedure. And then for the men who have worse leakage, we can actually completely give you a new sphincter by going in the same area to your urethra, and think of like a little donut, and you put the donut around the urethra, and it's a balloon, and it basically snaps shut. And so it's always holding your urethra closed so you don't leak. And then when you want to pee, you basically got to hit a button in your scrotum, another scrotal pump thing, to open it up, and then you pee through it, and then it kind of closes on its own over the next 60 to 90 seconds or so. So it does take a little bit more work. You have to actively do something, but even the worst cases of incontinence, you can treat with this because it's literally closing everything shut. So this is the way it works. It's the same idea, 3 pieces, a pump in the scrotum, a reservoir in the body, and the active component, which is the cuff right there on the urethra. And the cuff is a donut or a balloon that's always closed, and then you open it to pee, basically. And so this can turn even the leakiest guy bone dry. And it's pretty amazing to see how people's life changes when, a lot of times leakage can lead to a huge quality of life problem, right? You don't leave the house, you don't want to see your friends, you don't want to go do stuff, a lot of stuff like that. But you can basically fix that with one of these 2 surgeries, and it's pretty miraculous. A lot of times the advanced prostate cancer patient may have both significant ED and significant stress incontinence, and we can also do something for both, although usually we'll fix the plumbing, i.e. the incontinence part first, get them dry, and then fix the penis part. But that's also very common. This is here. Kind of explained it already, so I just want to look at the picture. You hit the button, it opens the cuff, you pee, and then the cuff closes on its own again. That's how that works. So also an outpatient procedure, also about an hour, tiny incision. Actually, there's 2 incisions. There's one little one. Usually there's 2 up on the lower groin, and then one kind of in the perineum. Similar idea, 2 weeks strenuous exercise, that kind of stuff, and then usually it's 6 weeks, and then we turn it on. So after you get the surgery, you just have to leak for a little bit until we turn it on. But once we do, it's like this miraculous, oh my God, I don't have to wear diapers again. Pretty cool. And also same thing. People are very happy when these issues, erectile dysfunction, leakage, these are significant quality of life issues. And I think that you can't underestimate the impact that you can have on patients by helping them fix these things. And it's certainly very rewarding as a career, and it's really fun surgery to do, especially when you're so hyper specialized and basically just do a little handful of things. Now, coverage is also fully covered by Medicare, and in fact, this one is generally much better, or there's more coverage for this than for penile implants, because insurance companies, and all their wisdom, sometimes they're like, leakage, that's a problem. Sexual dysfunction, that's not a problem. And I hate it, and the patients hate it, and nobody likes insurance companies. Let's put it that way. But we have to work with them. And so basically, that's what the implant does. It gets you dry, or basically not the implant. A sling or a sphincter gets you dry. And similar idea of risks and all that kind of stuff, bleeding, pain, infection, whatnot. So that's, if you've had prostate cancer and you've had it treated and you're dealing with some of these issues, we got 33 urologists in the group. Some are great at treating cancer. Some are great at treating bladders. Some are like me and do this kind of work. And there's always one of us that can probably help you out.